Going forward, academic healthcare centers are going to have to transform how they actually do their business. They're going to have to transform how they care for patients and how they educate students. So what can they do to improve the way they care for patients? Let's begin. There are 4 ways they can address the problem. First, I call the 80-20 rule. If you look at the healthcare that most academic health centers provide, most of it might be called commodity care. They do appendectomies, regular deliveries of babies, exacerbations of emphysema, skin infections, simple pneumonias. You really don't need to be in a high-tech academic health center to get that kind of care. You can get very high-quality care for those services at cheaper prices in a lot of community settings. Now, it is true academic centers provide high-end specialty care, really innovative services, but that's a minority of the activities they do. Fetal surgery, immune-targeted cancer therapies, organ transplantations, complex chemotherapies. Well, that is something they can charge a premium price on. But for the commodity care, for the appendectomies, the CT scans, the normal deliveries, they actually have to get the prices down. Well, that leads us to the second way they can transform themselves, and that is lean process improvement. Lean was developed at Toyota and other manufacturers to really make sure that everything they were doing was adding high value to the product. A number of healthcare systems have adopted Lean and gone through the process. For example, Denver Health, affiliated with the University of Denver, has adopted Lean. And over 5 years, they were able to cut costs over $150 million and increase their clinical capacity 5% per year going forward. I think all hospitals, and certainly all academic health systems, need to adopt Lean. One of its other advantages is it engages everyone from the custodian to the chairman of medicine and other departments in the process of trying to improve the efficiency of the hospital. Another thing that hospitals, academic health centers are going to have to do is actually emphasize quality evaluation and quality reporting. Too often now in the United States, we think quality is measured by U.S. News and World Report. That is a terrible ranking system. I once tried to unpack it and look in under the hood to see how they ranked hospitals, and it's pretty pathetic. First, they only use one important quantitative metric, and that's 30-day hospital mortality for Medicare patients. Now, I'm not saying 30-day hospital mortality isn't important. It is very important, but it's very limited. It applies to a very small number of hospital conditions. For my specialty, cancer, it's really irrelevant. We don't look at 30-day mortality, we look at 5-year survival. Second, a large part of its rankings depend upon reputation, what other doctors, who may not know anything about the hospital, say about it. It's a terrible way of measuring quality. Going forward, academic health centers are going to have to want serious quality measurement to show that they do provide superior quality that justifies higher costs. And fourth, they're going to have to transform how they actually provide medical education and medical training to interns and residents. It's going to have to be shorter, smarter, and more team-oriented. Today, medical training has little emphasis on health systems or policy, little or no clinical training outside of the hospital, little integration with other healthcare providers like nurses, dentists, social workers, pharmacists, and little population health training. That all has to change. First, medical schools have to be shorter, and I think by the end of the decade, we'll see a progression to 3-year medical training. As I mentioned at the start, the medical training of 4 years based on 2 preclinical years and 2 clinical years done in hospital is really 100 years old, and it's totally unnecessary. My institution, the University of Pennsylvania, spends only 18 months in preclinical work. Duke and Yale are down at 1 year to 15 months. We know that top flight medical students can be trained in a much shorter amount of time by reducing preclinical training. In addition, during clinical rotations, a lot of students spent time auditioning. Rather than focusing on learning, they're actually showing their skills to hospitals where they want to become interns and residents. That doesn't seem like a very efficient way of learning. So I think over the course of the decade, we're going to see top medical schools shifting more to a 3-year curriculum with shorter preclinical training and more focused clinical training. Second, medical training, especially for interns, residents, and medical students, needs to move outside the hospital. As we've seen, care for most patients is going to move out of the hospital and use a lot more digital medicine. The idea that medical students, interns, and residents spend most of their time at the hospital and not in clinics or nursing homes or patients' homes is antiquated. They have to learn how to care for patients in these other settings, how to use telemedicine and digital medicine to monitor their patients and to interface with their patients. That is going to be an essential new way of training people. Third, it's no longer going to be the doctor-patient relationship. Care going forward is going to be more the healthcare team, the patient, and the caregivers. And so doctors are going to have to learn and be trained with other healthcare providers, nurses, dentists, pharmacists, social workers, and others. Figuring out how to organize the team to efficient care and to deliver the best care to patients, I think, is a skill that we're going to have to develop and train interns and residents with. Fourth, during medical training, we have a lot of emphasis on research, and in particular, laboratory-based research. But what we really need is more emphasis on management. Students need to learn how to manage patients. They need to learn how to change manage, how to use large data, how to negotiate, how to lead teams. All of these management skills are not currently in medical training. I think going forward, we're going to have to see more integration of business school curricula with medical training. And finally, there has to be more focus on population health. As we evolve to integrated delivery systems that are responsible for a population, the health teams will need to learn how to manage the population, how to proactively identify patients at risk, communicate with them, and monitor them much more carefully. So I think these elements are going to be necessary to transform how academic healthcare systems provide their medical education. We're going to see 3-year medical schools. We're going to see half a physician clinical training be done in the outpatient setting outside of a hospital. There will be more training with nurses, dentists, pharmacists, social workers, and other healthcare providers. And I think the medical school curriculum is going to have to be redesigned to include more management training and more population health. Overall, we're going to see a very big change in medical education, despite the fact that it has not really evolved over the last 100 years. In our final session, we're going to look at how all these effects of the Affordable Care Act on the delivery of care, on insurers, on employers, on academic health centers and medical education are all coming together to really make one very large transformation, and that is on healthcare costs. And so the last megatrend is about how the Affordable Care Act is going to impact healthcare inflation and the future of American medicine.